Okay, hello everyone, and welcome to a new session of clinical pharmacology and drug therapy. Today we are going to speak about osteoporosis. I am Dr. Khalid Hassan, professor of clinical pharmacology and drug therapy. Let's get started. So, as osteoporosis is characterized by progressive loss of bone mass and lead to the skeletal fragility. The bone become weak and brittle. This is due to the imbalance between due to the imbalance due, this one due to the imbalance. Okay, this is due to the imbalance between the bone resorption and bone formation. Here we are talking about two type of cells in the bone. We have osteoblast and osteoclast. Okay, so the osteoblast responsible for bone formation and the osteoclast responsible for bone resorption. Okay, so here we talk about osteoblast and responsible for bone formation. Then we have osteoclasts responsible for bone resorption. When we have this imbalance between the osteoblast and osteoclast, this will lead to the decreased bone density and increased risk of bone fractures. And normally we see that in spine and the hip and the wrist. And sometimes people maybe don't suffer from the fracture and become like silent. This disease may be silent until the person or the patient start maybe suffering from spontaneous fractures. Most commonly seen in postmenopausal women and in elderly adults. So this one related to the deficiency of estrogen hormone here, and in the older subject because we have the balance between osteoblast and osteoclasts. In this slide here, we discuss the steps for the healthy bone, what happened in healthy bone and what happened in the bone suffer from osteoporosis. Okay, so you can see here in healthy bone, we have two main cells as we discussed it in the beginning. We have osteoblast responsible for bone formation. Then we have osteoclast responsible for bone resorption. Osteoblast responsible for building the bone, building up the bone, and osteoclast responsible for cutting down the bone, or we call this one bone resorption. And in healthy bone, you can see the healthy bone here. That we have equal, maybe relationship between osteoblast and osteoclast, and there is no risk of osteoporosis. So here we have balance between bone formation and bone resorption, and there is no risk of fractures. However, if you move to the osteoporosis, what happened there? We have two main cells again, but as you can see here, the osteoclasts increased activity of osteoclasts that maybe represent the cell responsible for bone resorption, or decreased activity of osteoblasts. So the results here, if you clean this one here, okay, I will say here, for example, increase activity of osteoclasts or decrease activity of osteoblasts. Okay, so what happened here? This will lead to the imbalance between bone resorption and bone formation, and the patient suffer from this will lead to the bone formation, release calcium, increase calcium in the blood, and risk of fractures. And this fracture could be spontaneous. Okay, moving to the vitamin D and calcium. This is two main factors regulate the bone resorption and formation. We have vitamin D, we have calcium. So two main factors, two main agents, endogenous agent and exogenous agent, responsible for bone formation and resorption. Okay, and we know that through the skin, the sun will be affect the skin, and the skin will absorb ultraviolet light. Okay, the skin will absorb the ultraviolet light, and the sun start synthesize the vitamin D from the sun. And the first substance coming from the sun called 7 dehydroxy the first maybe substance formed from the through the skin from the sun will be 7-dehydrocholesterol. Okay, moving next, 7-dehydrocholesterol will convert to the vitamin D3 and another name cholecalciferol. So we need to remember that vitamin D3, another name for vitamin D3, cholecalciferol, and another source for cholecalciferol, vitamin D3, and we have fish oil or omega-3, another rich source of vitamin D3. We have another form of vitamin D, it's called vitamin D2, and another name for vitamin D2 is like orgocalciferol, and most of the food provide this type of vitamin D, and eggs one of the main source for that, for example here. So you can see here we have two main sources, vitamin D3 and vitamin D2. Vitamin D3 could be coming from the sun or the fish oil, vitamin D coming from the other food and eggs, and this will lead to the formation of calcidiol. So what happened here, the vitamin D2 and D3 will arrive to the liver, and in the liver we add another hydroxy group to the vitamin D, and the vitamin D will be converted to the calcidiol, and another name for calcidiol, 25 hydroxy vitamin D3. So we can type it here, 25 hydroxy vitamin D3. So you can see here we have addition the first hydroxy group to through the liver, and then this calcidiol 25 hydroxy vitamin D arrive to the kidneys. In the kidneys they add another hydroxy group, and you can see here another hydroxy group. Okay, we have 125, we have 125 dihydroxy 125 dihydroxy vitamin D3, and this one considered the active vitamin D. So the question here, which of the following is the active vitamin D? Cholecalciferol, orgicalciferol, calcidiol, or calcitriol? So you can see here we have calcitriol, calcidiol, cholecalciferol, orgocalciferol. So this one is very important to remember this cascade here. We can create several questions. What type of provitamin synthesized in the skin? 7-dehydrocholesterol. What type of maybe vitamin D available in the fish oil? Vitamin D3, cholecalciferol. In the liver, what type of vitamin D will be formed? Will be calcidiol 25. In the kidney, 125. Which one is active? 125 dihydroxy vitamin D. Okay, next slide will present the effect of calcitriol on bone, how active vitamin D calcitriol, how active vitamin D calcitriol impact the bone. Calcitriol, active vitamin D, work on the two main places, two main organs. We need to remember that. They work mainly on the intestine by enhancing calcium absorption from the GI system. Sorry, and work also on the kidneys. And the kidney reduce excretion of calcium from the kidneys. So try to enhance absorption of calcium from the GI system. On the kidney, reduce excretion of calcium in the urine. Reduce excretion of calcium in the urine, and enhance absorption of calcium from the GIT system. So you can see here we have two main action for active vitamin D, work on the intestine and on the kidneys. Also vitamin D work on the bone, and we are going to discuss that later on. Okay, vitamin D, osteoclast activity, vitamin D on the bone. We try to study the effect of vitamin D on the osteoblast and osteoclast. This type of cells here, we try to discuss the activity. Calcitriol, 125 dihydrovitamin D, active vitamin D, stimulate osteoblasts. That's very important step. Stimulate osteoblast, promote formation of osteoblast, and this will lead to the bone increase, enhanced bone formation. So this is a normal activity of vitamin D. So vitamin D will activate osteoblast, and this type of cell responsible for bone formation. On the other hand, vitamin D also responsible for regulate osteoclast. Vitamin D work with the BTH, and BTH stands for a hormone called parathyroid hormone. Okay, by working with the BTH, this will stimulate osteoclasts, okay, activity. When we have a low calcium, low level of calcium, and this will lead to the release of calcium from the bone. So you can see here the vitamin D responsible for balance of calcium, responsible for regulate osteoblast, responsible for bone formation, responsible for maintaining blood calcium level within the normal range. Okay, the next slide will discuss the effect of low calcium level, low blood calcium level, and high blood calcium level. What is the compensatory mechanism for this response? Okay, when we have low calcium level, as you can see here, when we have low calcium level, the result will be number one, we have low calcium level. The result will be osteomalacia. So here we're talking about the consequences when the patient suffers from low blood calcium. So the patient, maybe talking about adult, may suffer from osteomalacia, and that means softening the bone. If you speak about children, the children may suffer from rickets, and the bone lead to the improper bone formation, and there is a risk of bone fractures. The bone become weak and predisposed to the spontaneous fracture due to the poor mineralization. Okay, low blood calcium. What happened here? What is the compensatory mechanism when someone suffers from low blood calcium? As you can see here, two main hormones will be activated when we suffer from low blood calcium. The first hormone will be parathyroid hormone and vitamin D, active vitamin D. So BTH will be activated and vitamin D will be activated when we have low blood calcium, and this will affect the bone. BTH start stimulate the bone. Okay, BTH start to increase resorption of bone, bring the calcium from bone to the blood. Okay, activate osteoclasts. So when activate osteoclasts and work on the kidneys and enhance excretion of work with the BTH work on the kidneys, decrease excretion of calcium in the urine. So the end result will be, for this one here, the end result will be, okay, so the increase osteoclasts. This will move the calcium from the bone to the blood. Okay, to the blood here. And decreased excretion also will lead to increased level of calcium in the blood. So you can see the compensatory mechanism here. BTH work on the bone and the kidney. In the bone, enhance osteoclast, and on the kidney, decrease excretion of calcium in the urine, and this will lead to the increased level of blood calcium. Okay, moving to the result of activation of vitamin D. This will work on the intestine, on the kidneys. So on two main organs, vitamin D work on the kidneys and on the intestine. And in previous slide, we present the effect of vitamin D on the bone also by affecting osteoclasts and osteoblasts. So here what we have, you can see here on the intestine, enhanced absorption of calcium, and on the kidneys, decreased excretion of calcium in the urine. Okay, the net result here from the working on the vitamin D and BTH, okay, the net result to restore normal blood calcium, normal level of blood calcium. So now we have normal blood calcium level. That's great. The patient now, the blood, the calcium in the patient is normal. Okay, when we have normal blood calcium, you can see here normal blood calcium practice negative feedback on this axis here between the low blood calcium and two main hormones. So we have the activity now. Now we understand how our body work when we suffer from low blood calcium. BTH will be stimulated, vitamin D will be activated, and the end result will be restores normal blood calcium, and they give order to this hypothalamus pathways to say, okay, stop. We have enough of we have enough from calcium in our body. Okay, moving to the next step here. What happens when you have high blood calcium? Of course, here we need to emphasize on something. Uh, when the patient, for example, we have several causes of high blood calcium. Another name for high blood calcium, we call this one hypercalcemia. Hypercalcemia, one of the important causes of hypercalcemia, called hyperparathyroidism. So the main causes for the high blood calcium, the main cause for high blood calcium, a disease called hyper, mean increase, hyperparathyroidism. So para talking about BTH hormone, and we have increased activity. So when you have increased level of BTH, this will lead to the increased level of calcium in the blood, and the patients suffer from hypercalcemia. So you can see the results here, like hypercalcemia, for example, and this will lead to the high blood calcium. The patient here suffer from hypercalcemia. Okay, what happened here for the compensatory mechanism? Okay, so when you have high blood calcium, another hormone will be interfering, and this hormone called calcitonin, and the abbreviation for the calcitonin CT. Okay, the hormone will be activated. This hormone produced from thyroid gland, and this hormone called calcitonin, okay, or calcitonin. Calcitonin affect or stimulate or work on the bone and kidneys, and the main function of calcitonin to decrease blood calcium when you have high blood calcium. So the main hormone will be activated, and produced from the thyroid gland will be calcitonin. Calcitonin work on the bone and kidneys. What is the results here? So working on the kidneys, calcitonin inhibit release of calcium from the bone. On the kidney, increase calcium in the urine, and the end result will be decrease level of high blood calcium. So the end result you can see here, this will lead to the decreased calcium in the blood. Again, decrease calcium blood level. So when you have high, activate calcitonin, this will restore normal blood calcium by the activity, by working on the kidneys, enhance excretion of calcium in the kidneys, and decrease absorption of calcium from the bone. Calcitonin considered one of the options for treatment for osteoporosis, because as you can see here, calcitonin inhibit the release of calcium from the bone, and this is a give option for a calcitonin to use for patients suffer for treatment for patients suffer from osteoporosis. Okay, due to the inhibit release of calcium, keep the calcium in the bone. Okay, moving to the etiology of osteoporosis and what type of osteoporosis you have. They said that we have two main type of osteoporosis, primary and secondary. Primary could be type 1 and type 2. Type 1 related to the postmenopausal osteoporosis, and type 2 related to the age related. We call this one primary. We have secondary, could be drug induced, could be medical condition. So we have a list of medications, and we discussed that in the beginning, or we are going to discuss it later on. And we have cases or disease may cause, for example, osteoporosis, such as Cushing syndrome, for example, may cause osteoporosis. Okay, so one of the case there. Okay, so moving to the etiology here, the causes. Could be certain drug, could be endocrine disorder, gastrointestinal, genetic, hematologic disorder, hypogonadal state, lifestyle, and other factors. So as you can see, category here, we have primary, type 1, type 2. We have secondary, drug-induced or medical condition. Okay, regarding drug may induce osteoporosis. Okay, moving to the drug may induce osteoporosis. As you can see, we have aluminum antacid, this medication used for peptic ulcer disease. Then we have anticoagulants, heparin, when we use it for long time and high doses. Then we have anticonvulsants, for example, phenytoin, anti-epileptic drugs, phenytoin, phenobarbital, carbamazepine, brimidone. All these medications may cause osteoporosis. So when you approach patients from osteoporosis, we need to take a drug history from the patient. Be sure the patient didn't, or the patient maybe did take any medication. You have to be maybe confirm or exclude any medication may cause drug-induced osteoporosis. Aromatase inhibitors, the medication used for the breast cancer. The dipomedroxyprogesterone, long-acting contraceptive. Furosemide, strong diuretic, and used for the treatment of edema. Then we have gonadotropin-releasing hormone, GnRH, and agonist. Okay, long-term use of glucocorticoids, cortisone in general predispose or may cause osteoporosis. Methotrexate, anti-cancer drugs, use methotrexate and other medication for psoriasis and medication for rheumatoid arthritis. A proton pump inhibitor, peptic ulcer disease treatment, such as omeprazole. SSRI, selective serotonin reuptake inhibitor, such as paroxetine, fluoxetine, and other medication may cause osteoporosis. And thiazolidine, and this medication prescribed for type 2 diabetes. So we have the list of medication should be discussed and exclude from the treatment or replace or switch or decrease dose. We need to manipulate the situation, what is the best for the patient to approach, how to try to eliminate the effect of drug-induced osteoporosis. Okay, thyroid hormone, yes, for example, levothyroxine, when we have excessive replacement therapy, high dose of replacement therapy may cause osteoporosis. Okay, speaking about the pathophysiology of osteoporosis, and here we are talking about bone remodeling. I'm going to share with you article published on the nature.com and this one on the website. Okay, by looking on the osteoblast on the Google images, we have this image here from article published. If you click on this link here, if I click on this link, they will take you to the article published on nature.com. This article looking on the osteoclasts, and if you scroll down from this article to this image here, I click on the image. Okay, this is a bone remodeling. In healthy subject, you can look at the bone density here, normal bone density, and compare that. What we have here, we have bone resorption equal to the bone formation. We have enough number of osteoblast bone formation, cells responsible for bone formation. We have enough number of osteoclasts, and we have equal between resorption and formation. However, with an elderly postmenopausal woman here, you can see here we have elderly and women. So gender and age, women and increasing age, two things. This will lead to the increased osteoblast activity, osteoclast number, and decreased osteoblast activity and osteoclast number, and this will lead to the osteoporosis. And you can see here the fractures, the maybe bone fractures here. Okay, moving to our lecture. So you can see here the bone remodeling is already presented. Okay, pathophysiology, we discussed a little bit of interaction between the hormones. Calcium, the primary hormone responsible for regulated calcium, responsible for regulated the bone, and you know that calcium, our calcium and blood calcium regulated by parathyroid hormone and vitamin D calcitonin. So three main hormones regulate calcium in our body. Number one, parathyroid hormone, vitamin D, calcitonin. So these three hormones, one, two, three, these three hormones responsible for regulation of calcium. Parathyroid hormone, parathyroid gland release PTH when you have low calcium level. We already discussed that in the previous slide, and we discussed the consequences. I recommend you to go and read the information. Vitamin D help to intestinal absorption of calcium and phosphor magnesiums from the GI system. Vitamin D work on the vitamin D. When you have vitamin D activate, increase vitamin D, increases in vitamin D level, okay, and decrease BTH level. And the result here related to the negative feedback. Okay, increased vitamin D increases bone resorption to prevent symptomatic hypocalcemia. So we have like dual function for the vitamin D. Calcitonin released in response to the high serum calcium, and we have it in the previous slide. Decreased absorption from the GI system, and increase enhanced excretion from the renal or from the kidneys. All these lead to the control high calcium level, and this will lead to the decreased calcium level in the blood. Okay. Now, what happened when you have when you prescribe cortisone to your patient, glucocorticoid? Glucocorticoid, maybe we have several actions, and we discussed that in details in the previous slide. It's not this one here. We have four main mechanism of action. I recommend you to maybe review the lecture regarding the glucocorticoids lecture, and we explained in detail why cortisone may cause osteoporosis. We have four main mechanisms, and the mechanism is very important because we can work on this mechanism to oppose the action of cortisone in inducing osteoporosis. Okay, signs, symptoms, and screening diagnosis. Most of the time, the osteoporosis is symptomatic, no symptoms. Patient may suffer from spontaneous fractures. Patient may suffer from bone pain. Patient suffer from losing height, and patients may suffer from kyphosis. How we can diagnose the situation, screening the osteoporosis. Normally, the gold standard will be measuring bone density, BMD, by using DEXA for the hip, the spine, the forearm, and we use a T score as a guidance for us for diagnosis, and we have table for that for diagnosis. Okay, you can see the table here. Body mass index, we have normal body mass index, normal bone density. If we have the T score equal or more than -1, then we have low bone mass, osteopenia, between -1 to -2.5. We confirm diagnosis of osteoporosis if the T score less or equal -2.5. We consider the patient suffer from severe or established osteoporosis if the T score less or equal -2.5 plus one or more fractures. So again, normal, osteopenia, osteoporosis, severe osteoporosis. More or equal -1, -1 to -2.5. Osteoporosis less than -2.5. Severe, less or equal to -2.5 plus one or more fracture. Who is a candidate for the screening? Who is candidate for the screening? All women above 65 and older, men more than 70 and older. We start with the younger age, okay, younger age with the equivalent risk factors. So if the patients are from risk factor, for example, here we go the screening. Special population, for example, here if the patient take cortisone, anti-estrogen, anti-testosterone, this is candidate for the screening for bone density. If the patients are from rheumatoid arthritis, is candidate for the bone density measurement. Okay, how to approach the patient here? We have some recommendation. First of all, we start with the non-pharmacological approach. Preventive measures. We try to ensure that the patient take enough calcium, the patient take enough vitamin D. So our goal, for example, from calcium 100 milligram per day, vitamin D 30 to 50 nanogram per milliliter, calcium supplementation. We can have it like we recommend patients to take a calcium supplement if they don't have adequate intake of calcium in food. We recommend patients to limit caffeine, such as 1 to 2 servings per day. We recommend patients to stop smoking and limit alcohol. All these maybe help to reduce a risk of osteoporosis. All these considered like non-pharmacological approach. Ensure intake of vitamin D, ensure intake of calcium, limit caffeine, stop smoking, limit alcohol consumption. Okay, calcium supplementation. We have several type of calcium available in the market. Calcium carbonate, one of the most important one, and calcium carbonate to prevent provide 40% of elemental calcium, inexpensive medication, and need to be taken with food for best absorption. Calcium carbonate, calcium citrate provide 21 percentage calcium element and could be used with food or without food. This is a provide better tolerated compared with the carbonate. So we recommend to go with the calcium citrate for the better toleration and maybe compliance because patient may take it with food or without food. When you prescribe calcium to your patient or when you recommend your patient to take calcium, you need to remind your patient that calcium may interfere with the absorption of several substances such as iron. So if you have women suffer from anemia and she's on iron preparation, and if you have patients suffer from thyroid disorder and the patient on levothyroxine, if you have patient take antibiotics such as tetracycline and fluoroquinolones, we need to make a gap. We need to make like separation between calcium intake and these components, ions, fluoroquinolones, tetracycline, thyroid, in order to prevent interfere with the absorption. Vitamin D essential for absorption of calcium from and bone healthy bone. Vitamin D is very important. Normally in the practice we have ergocalciferol, vitamin D2. We have cholecalciferol, vitamin D3. And patients who are at risk of osteoporosis, I recommend to avoid any medication may cause osteoporosis such as a glucocorticoid. Using glucocorticoid more than 3 months or more, the considered patient at risk factor of osteoporosis. So this one maybe represent the long term use or chronic use of osteoporosis. Okay, now we start speaking pharmacology. What treatment available? What type of treatment available for the osteoporosis? We have list of medication. We have bisphosphonate. This is the first group, and then we have other. So two main group available for the treatment: bisphosphonate, and then we have other. Bisphosphonate, alendronate. We have the first one, ebandronate. Then we have risodronate. We have etodronate, bamidronate, and telodronate, and then the last one we have zolendronate. So you can see here we have list of medication related to that. We have Fosimax, we have Actonel, Bonovia, for example, all these brand name. So please remember alendronate, ebandronate, risodronate. The other medication we have teriparatide, and teriparatide, this is a BTH. Then we have ebaloparatide, also BTH. Then we have raloxifene Avesta. Then we have calcitonin, miacalcin. We have denosumab, Prolia, and we have another new medication we discussed in the next coming slide. I recommend you to click on the medicine Medscape, e-medicine Medscape, for the article and read more details about that. Okay, moving to the guideline. What is the first line treatment for the, okay, I will go back again. What is the first line treatment for osteoporosis? We have a group of bisphosphonate. Okay, bisphosphonate first line treatment. And we have alendronate, Fosamax. We have ibandronate, Bonavia. Then we have risodronate, Actonel. We have zoledronic acid, Reclast. And we have monoclonal antibody, denosumab, Prolia. So this is considered like first line treatment, bisphosphonate and monoclonal antibody, denosumab. Okay, first line treatment here. Okay, so how can I differentiate between bisphosphonate, for example, here? Bisphosphonate regarding anti-resorptive activity, todronate has the activity 1, tolendronate 10 times more potent than todronate, bamidronate 100 times more potent than todronate, alendronate 1000 times more potent than todronate, risodronate 5000 times more potent than todronate, ibandronate and zoledronic acid, it's like 10,000 times more potent than the etodronate. So the most potent agent here, ibandronate and zoledronic acid. Okay, this is the first line treatment. What about the second line treatment? The second line treatment for osteoporosis, we have calcitonin, miacalcin, calcitonin. Then we have selective estrogen receptor modulator, discovered in the endocrine lectures. The one of the most important medication, raloxifene, and we can use estrogen plus bezodoxifene and the brand name Diovi. Okay. Then we have teriparatide, parathyroid hormone, ebaloparatide. Then we have another monoclonal antibody called rimosozumab, Evenity. So we have list of medication belong to the second line therapy for the osteoporosis. Okay, let me repeat the second line therapy for osteoporosis. We have calcitonin, we have raloxifene, then we have estrogen plus bezodoxifene, Diovi. Then we have parathyroid hormone such as teriparatide, ebaloparatide. Then we have monoclonal antibody rimosozumab, the brand name Evenity. So as you can see here, we have less of medication as second line therapy. But if you move a little bit to the previous slide show you the what we have here. This is the first line therapy for the osteoporosis, bisphosphonate and denosumab. Here I'm going to present some images for aldronate sodium through Google Images to show you the product, pharmaceutical product name. Okay, so you can see here, for example, we have 70 milligram alendronate sodium tablet, 70 milligram. Okay, one of these medication. We have alendronate more, large doses or smaller dose. You can see it here. We have alendronate 35 milligram. And we have more and more. So we have alendronate 5 milligram. So you can see here we have 5, we have 30, we have 70 milligram tablet of alendronate. So alendronate available in several pharmaceutical doses and depends on, we can recommend patient to take it once per day, twice daily, once weekly, and so on. Okay, bisphosphonate, how this medication work, how the bisphosphonate work. Okay, please remember bisphosphonate inhibit osteoclasts. Bisphosphonate inhibit osteoclast. And you remember that when we discussed that we have balance between osteoblasts and osteoclasts. This is in healthy subject. However, in patient with the osteoporosis, here we have maybe imbalance between, and we talk about this one here. We have imbalance between osteoblasts and osteoclasts. So we have increased activity of osteoclast or decreased activity of osteoblast. The question here, what is the target of bisphosphonate? The target for bisphosphonate work on the osteoclast, inhibit osteoclast activity, and this will lead to the decreased bone resorption. Okay, and the result will be increased bone density. Okay, moving to the next section here for us. Okay, moving to the next section here, we're looking on the efficacy and the frequency of bisphosphonate. As you can see here, for bisphosphonate form, we have alendronate, for example. The alendronate available like oral tablet and effervescent tablet. This tablet maybe could be placed on the cup of water and dissolved in cup of water and drink with the juice, for example. And this medication could be used daily or weekly. And this, for example, the effervescent tablet could be used weekly. It depends on the dose. We have 5 milligram, we have 30 milligram, then we have 70 milligram. So daily or weekly. Ibandronate use daily, monthly, or every 3 months. So when you prescribe it like IV, we use it every 3 months. Tablets, and depends on the dose, we use it daily or monthly. Ibandronate, we have 150 milligram for monthly or every 3 months. 100 milligram, 150 milligram tablet. Risodronate also we is available oral tablet or delayed release tablet. Could be used daily, weekly, or monthly. Okay, the last one here is very interesting, very attractive for us. Zoledronic acid. This in medication available like intravenous, and this is prescribed yearly, once per year, one injection per year. Zoledronic acid. Again, we have some images here to show you the doses for alendronate. We have 5, 10, 25, 70. We have denosumab here as Brolia, and then we have zoledronic acid. You can see the injection for IV. Okay, bisphosphonate, speaking about pharmacokinetic, how this medication work, what is the effect of our body, for example. You can see here when you prescribe bisphosphonate, consider like poor oral absorption, less than 1% will be absorbed significantly reduced by food. Therefore, the patient recommend to take this medication on empty stomach. When we prescribe alendronate, take it on empty stomach. What happened else? They said take 30 minutes before meals because we need to enhance absorption, and we ask the patient to sit up or remain standing or like sitting for 30 minutes post dose in order to avoid any mucus irritation for the GI system. Okay, plasma clearance, the medication rapidly cleared from the plasma. Okay, the medication strong binding to the hydroxyapatite of the bone. The bound drug in bone cleared some of them in hours, and some of them stay on the bone for years. Elimination of bisphosphonate mainly through the kidneys, and we need to avoid use this medication in patients with a severe renal impairment. Okay, so alternative route of administration, we have two medication available IV. We have zoledronic acid and ibandronate, and both of them available as IV when we have patient unable to tolerate the oral administration. For example, the patients are from peptic ulcer disease or with esophageal ulcer, for example. Okay, any adverse effect from the bisphosphonate? Yes, they said bisphosphonate may cause common side effect, diarrhea, abdominal pain, muscle pain. That's fine. We can control that. That's like common effect, common mild effect, diarrhea, abdominal pain, muscle pain. However, bisphosphonate may cause esophagitis. Bisphosphonate may cause esophageal ulcer. Okay, so esophagitis or esophageal ulcer. For this reason here we can minimize the esophageal irritation by asking the patient to remain upright when taking oral bisphosphonate at least 30 minutes to 60 minutes. Remain upright, don't maybe go to the bed, for example, don't sleep when you take this medication for at least for like 30 minutes to 1 hour. Okay, serious uncommon side effect, osteonecrosis of the jaw, a typical femur fractures. This one happened when we have long use of bisphosphonate. So two main uncommon serious side effect, osteonecrosis of the jaw and typical femur fractures. Okay, guidelines here, they said in order to avoid these side effects, we recommend patients to take drug holiday. If they take oral bisphosphonate, after 5 years of treatment, take drug holiday, stop the medication for a period of time. If the patient takes zoledronic acid IV, stop this medication after treatment, after 3 years of treatment. Okay, so to avoid side effects such as osteonecrosis, a typical femur fracture, esophageal irritation, or any other side effect, we recommend patient to follow drug holiday after 5 years of oral or after 3 years of IV. Okay, this I believe to conclude our topic about the bisphosphonate. The next medication belongs to the first line therapy, denosumab, Prolia, and we have image for denosumab, Prolia. Okay, so this was the Google image here for denosumab, Prolia. You can see it available like pre-filled syringes, Prolia, denosumab. Okay, so it's expensive medication. Okay, Prolia, looking on the Prolia here. Okay, Prolia mechanism of action. This work on the Rankel monoclonal antibody, Rankel. Okay, and inhibit osteoclast formation, inhibit osteoclast function. This medication prescribed subcutaneous. Okay, this medication prescribed subcutaneous, 60 milligram every 6 months, 2 injection per year. Denosumab. Denosumab approved for the postmenopausal osteoporosis at high risk of osteoporosis. We prescribe denosumab. Okay, denosumab. Okay, that's first line treatment for the patient with osteoporosis and at high risk of fractures. So the main reason for prescribing denosumab, this expensive medication, when we have high risk of fractures, and we have it like first line therapy. Okay, postmenopausal woman with osteoporosis with high risk of fractures, denosumab. And what is the advantage for denosumab? They said this is a first drug of choice, or like drug of choice for patient with a renal insufficiency. That's great. But they said if the patient at end stage renal disease, we don't recommend to use this medication. Stop this medication. If the patient on dialysis, stop this medication. They said because there's a risk of hypocalcemia. Okay, so for the patient with the impaired renal function, that's drug of choice. But if you have severe renal function, it's not recommended due to the risk of hypocalcemia. Okay, warning and precaution here. This medication may increase risk of infection, hypersensitivity reaction, cause of hypocalcemia, mean here we talk about decreased calcium in the blood. This medication may cause rare risk factors such as osteonecrosis of the jaw, typical fractures, and bone pain, joint pain, muscle pain. So all these related to the denosumab, and this is belong to the monoclonal antibody. How this medication work? Okay, let me share the screen from the Google images, and this is published on ResearchGate. Okay, so you can see here what we have. We have rank receptor. Okay, we have rank receptor. Then we have rank ligand. Denosumab, we have it here like a yellow color. Then we have bisphosphonate. And we have two main type of bone. We have osteoblast and osteoclast. And when you prescribe denosumab binding to the rank ligand. Okay, denosumab bind to the rank ligand, and in this case, it prevent binding or activate. It's prevent binding or activate rank ligand. As you can see here, rankel responsible for activation of osteoclast. So we go back to my slide again. So what happened here? This medication inhibit rankel. This one, rankel, responsible for activation of osteoclast. So rankel here, this kind of bind to the osteoclast and activate the osteoclast. Okay, this is how this maybe pathophysiological effect. Okay, moving to the what happened here when you prescribe denosumab monoclonal antibody inhibit rankel, and this will inhibit this process here, prevent rankel from binding to the osteoclast. Okay, and the result will be decreased bone resorption. So the main target for the denosumab and bisphosphonate will be osteoclasts. Okay, denosumab. Next to the next medication here, talk about second line treatment. Second line treatment here, as you can see, we have calcitonin, we have raloxifene, we have estrogen plus bezodoxifene, and this belong to the SERM, stand for selective estrogen receptor modulator. Then we have teriparatide, belong to the parathyroid hormone. Abaloparatide belong to the parathyroid hormone, and the new medication belong to the monoclonal antibody called remodeling Evenity. So we have less of medication considered like second line treatment for the osteoporosis. Again, let me repeat the second line treatment: calcitonin, SERM, raloxifene, Diovi, and we have teriparatide. Then we have remodeling Evenity. So this is the second line treatment. So we need to remember, differentiate between first line therapy and second line therapy for the for osteoporosis. Okay, moving to the next medication here to like brief explanation for teriparatide, abaloparatide. As you can see here, this medication work as agonist on BTH agonist. Please remember that. BTH agonist, that means stimulate BTH. And this medication may be prescribed once daily, as you can see here, injection, once daily subcutaneous. Okay, this medication increase activity of osteoblast activity, increase bone formation, and increase bone strength. Okay, so this medication considered like alternative treatment. It's not first line treatment. This agent may be reserved for patients who are at risk of high fractures, who fail to respond to the other medications such as alendronate, denosumab. It's not first line therapy. Parathyroid hormone teriparatide, it carry the risk of hypercalcemia, increased level of calcium in the blood. So when you prescribe this medication, it may cause hypercalcemia. If you go back a little bit and review what we have in the denosumab carry the risk of hypocalcemia. Other black box warning for the calcitonin will be osteosarcoma, like bone cancer. So if you click on the link here and see the black box warning for the teriparatide or teriparatide, so we have it here for the teriparatide. We look on the black box warning here. You see the rectangle black box warning. We have it here. They said increased incidence of osteosarcoma, type of bone malignant tumor. So we need to remember that and take it in consideration. And this medication for the subcutaneous injection. Okay, teriparatide, and we have two main risks: hypercalcemia and osteosarcoma. So the question here from teriparatide: which of the following medication used for osteoporosis, but this medication may increase risk of osteosarcoma? Teriparatide. Which of these medication you associated with the increased risk of hypercalcemia? Teriparatide. Which of these medication work by increased activity of osteoblast? We have teriparatide. Which of these medication considered like agonist for ABTH? We have teriparatide. Okay, next medication we have raloxifene. Raloxifene considered belong to the estrogen, but this raloxifene is considered like selective estrogen receptor modulator, SERM. Low level, okay, according to the several study literature review, they found a low level of estrogen. Uh, we have the estrogen level will be decreased during menopausal or postmenopausal woman, and this will activate osteoclast and decline bone mass. Okay, the study found if you replace the estrogen, this considered like effective approach for prevention of postmenopausal bone loss. Estrogen may increase risk of now. Okay, the postmenopausal woman suffer from decreased level of estrogen. Okay, the best way to replace estrogen. However, estrogen may carry the risk of cancer. Estrogen treatment may carry the risk of endometrial cancer, breast cancer, stroke, deep vein thrombosis. We don't recommend to use estrogen for osteoporosis. Okay, no longer recommended. Okay, for this reason here they have something alternative for that called raloxifene, selective estrogen receptor modulator, approved for treatment of osteoporosis. Raloxifene. Raloxifene, the brand name Evesta. Raloxifene has estrogen-like on the bone. Okay, raloxifene, and okay, stimulate the bone. What happened to the endometrial and breast and antagonist action? So estrogen antagonist on the bone, on the breast and endometrial cancer, antagonize the effect of estrogen on the breast and endometrial cancer, and estrogen like on the bone. So try to stimulate the estrogen receptor in bone and antagonize the receptor on the breast and endometrial. And they found in this case raloxifene increased risk or increase the bone density without increasing risk of endometrial cancer and breast cancer. Okay. However, this medication showed it has not been shown to reduce non-vertebral or hip fractures. Raloxifene considered like alternative treatment for bisphosphonate and denosumab. So the first line treatment, bisphosphonate, denosumab, and the alternative will be raloxifene, especially when we speak about postmenopausal osteoporosis. Okay, the only one things we need to remember with the Evesta, raloxifene, increased risk of deep vein thrombosis. Okay, so deep vein thrombosis with the Evesta would need to be remembered. Calcitonin used for treatment of osteoporosis. Okay, the calcitonin, how this medication work, antagonize effect of BTH, inhibit bone resorption. Calcitonin less effective than other agent, no longer recommended as a routine treatment. As you can see here, we have it like nasal spray. Okay, calcitonin could be used for the unique property by relief pain associated with the osteoporotic fractures. As you can see here, available like intranasal treatment. Calcitonin, miacalcin. Okay, the last medication in the group for the second line treatment, second line treatment, we have Avinity, and the medication name called rimocizumab, Avinity, AQQG, Avinity, and this one monoclonal antibodies, humanized anti-sclerostin, monoclonal antibodies, increasing bone formation. And is this first line? No, we don't recommend to use Avinity. It's only for menopausal women at high risk of fractures who are intolerant or refractory to other therapies. So this is not first line treatment. 2 injection dose back to back for once per month. 2 injection once per month for 12 doses. Patient may suffer from joint pain, headache, and injection site reaction. However, Evenity may increase risk of cardiovascular death, may increase risk of heart attack and stroke. So we need to remember these in black box warning. And if you click on the link here and bring it here for the to share it with you, you can see here FDA approved a new treatment for osteoporosis in postmenopausal women at high risk of fractures, and we have the medication name. Okay, you can see it here. Evenity Remosozumab AQQG, and for the treatment, this one prescribed uh, for the patient who are intolerant or refractory to the other treatment. Risk factors here: black box warning, cardiovascular death, heart attack, and stroke. We need to educate our patient. Okay, we need to educate patient to take adequate amount of calcium and vitamin D, consume balanced diet, regular performing weight bearing strength tests and balanced exercise. This will reduce risk of fall and prevent fractures. Avoid smoking, limit alcohol, take measure to avoid falls, and consider hip protection, for example, for the patient. Okay, this will conclude our lecture about the osteoporosis. We discussed the pathophysiology about the imbalance between osteoclast and osteoblast. We discussed maybe factors influence the bone remodeling. We bring out vitamin D. We discuss the calcium level. We discuss the calcitonin, parathyroid hormone. Then we discuss the approach for the treatment, non-pharmacological approach and pharmacological approach. For the pharmacological approach, we discuss the first-line therapy and the second-line therapy, alendronate, denosumab, first-line therapy. Then we have calcitonin, we have raloxifene, we have the romosozumab, and list of medication could be considered for the treatment, but we need to maybe compare between risk-benefit ratio for the patient. For example, we don't recommend to use estrogen for osteoporosis because there is a risk of breast cancer and endometrial cancer. This will conclude our lecture for osteoporosis. Thank you so much for your time and have a great day, everyone.